AlOsaimi, a surgeon from Kuwait. I'm presenting this short talk entitled Scoliosis as a rare risk factor for colon perforation during colonoscopy. In fact, it's a case report where scoliosis was mentioned for the first time in the literature as a rare risk factor for colonoscopic perforation. So we'll start with the case report. Of course, a written informed consent was taken from the patient for the sake of publication. My patient, she's a 66-year-old female. She has no past medical history, no comorbidities, and no previous abdominal or pelvic surgeries. And she underwent a colonoscopy, a routine colonoscopy for screening purposes under sedation. During colonoscopy, no abnormalities were detected, and the gastroenterologist noticed a sudden and massive abdominal distension, and the patient started screaming with pain, severe pain, so the procedure was stopped, and the patient was taken to the resuscitation room. And in the resuscitation room, she was hemodynamically stable. A protocol of trauma were started, an X-ray was obtained, and obviously you can see an error at the diaphragm, peritoneum. So obviously there is a viscous perforation. So we managed this patient by taking her for diagnostic laparoscopy after resuscitation with the fluid and antibiotics. There were no fecal soiling in the peritoneal cavity, and there was a small perforation about 1 centimeter in the anteromedial wall of the sigmoid. And the perforation site was prepared laparoscopically, and the patient was kept NVO with IV fluid, of course, and antibiotics. Eventually, she did well with a remarkable recovery. So, colonoscopy is a common procedure for the diagnosis and treatment and follow-up for colorectal pathologies. The incidence of iatrogenic colonoscopic perforation in diagnostic colonoscopy is range from 0.01 to 0.8 and up to 3% in interventional colonoscopy, where sneering or bulbectomy or injection is done. Now, the most common site of colonic perforation is rectosigmoid, and perforation and hemorrhage is common in the right side, in the right colon compared to the left colon by 2 folds. Now, the mechanism of iatrogenic injury, it could be direct mechanical injury with the tip of the instrument, with the tip of the scope. It could be due to sharp flexion during the maneuver, negotiating the bowel. So it can cause the injury. Other mechanisms of injury, pneumatic dilatation. There is some stricture and you are dilating. Over-dilatation can cause injury. And it could be due to thermal or electrical injury during therapeutic interventions, such as bulbectomy. The other mechanism of injury is pulling the scope against the vertebral column, which causes shearing effect. Now, reviewing the literature, the risk factor for iatrogenic colonoscopic injury, colonoscopic intervention, as I mentioned, age more than 75, and there is a reason beyond that. Most of the patients above 75, they have a already diseased colon with diverticulosis, for example. Patient with multiple comorbidities, and literature showed presence of 2 or more comorbidities can increase the risk of colonoscopic perforation by 2 to 4 folds, 4 times. The others are very well-known risk factor for chronic perforation, pelvic surgery, chronic obstruction, diverticular disease, where the endoscopist by mistaken the lumen of the diverticulum, the diverticulum as a lumen, so injury is there. Now, the review of the literature showed there is no gender or emergency endoscopy anesthetic method. Specialty or experience of the endoscopist is related to the incidence of colonoscopic perforation. Regardless if female or male emergency done under sedation or general anesthesia, it's not related to as a predictive value to the chronic injury. Now, I'm not go through this, but the management as overall is non-operative or operative, can be colonoscopic repair, can be laparoscopic or thorough laparotomy with or without primary anastomosis. Now, scoliosis and colonoscopic perforation. To know this relationship, we have to talk just a little about scoliosis. It's not our specialty, it's spine surgeon and orthopedic headache. So, but we have to have a little idea about it. So scoliosis by definition is a lateral displacement of the curvature of the spine, and it's common in females compared to males. There are several types: idiopathic scoliosis, congenital, neuromuscular or degenerative kind of scoliosis. Now the curvature could be dextro to the right side or levoscoliosis, and locations could be thoracic, lumbar, or combined thoracolumbar. Now scoliosis and colonoscopic perforation. The lateral displacement or the curvature of the spine wall results in distorted anatomy of the abdominal pelvic viscera, and there is a tension on the soft tissue anterior to the spine, loss of mobility of the colon or rectosigmoid due to acute angulation of the bowel. So the bowel is pulled. And this will increase the difficulty of colonoscopy procedure and interfere with the usual pathway of introducing the colonoscope. Usually by subconscious and expert endoscopist, you just go with the colonoscope blind, so you can go left, right, flex it to the up, then rotate it, then you are in. So the anatomy is distorted. This is not the case in scoliotic patient. And the other factor in scoliotic patient is the bone. The bone is a little bit sharp. So pulling the scope along this against the bone of the spine can cause what's called shearing effect and causing the injury. As a conclusion, patients with skeletal deformity such as scoliosis or kyphoscoliosis undergoing colonoscopy have a higher risk of iatrogenic colonoscopic perforation, and any sign of peritonitis should alert the endoscopist or the surgeon for such complication. Thank you. I'm pretty tired and exhausted after this long day.
Was nice and short, so it was kind of really rejuvenating. Something we don't frequently see.
So, if the audience has no questions, so then we can move to the presentation ceremony. So now we request our